Now, to start today's program, we're going to share a short video from Julie Temple. And Julie is the parent of Charlie, who is living with long COVID. So Julie has graciously contributed this heartfelt piece as a part of our Symposium art gallery, and it offers a powerful perspective from a parent's and a child's experience with long COVID. This video provides a meaningful lead up to our keynote speaker, Dr. Jonker. So we're going to play the video now if you'd all watch it. Thank you.
My name is Charlie. I'm 15, and when I got long COVID, I was in grade 6 and was 11. When I first got long COVID, I was just really tired all the time. I felt very bad about not being able to hang out with my friends. They would text me, but I would just have to reply and say, "Oh, sorry, I'm too tired." I felt like they would think I was just making excuses and didn't really want to hang out with them. But when I got into junior high and was homeschooled all the time, I lost a lot of my friends because I was too tired to go to school and too tired to hang out outside of school. Long COVID has impacted me way more than just losing friends. I also used to really love being in nature, but ever since I've gotten long COVID, it's been really hard for me to get out. I can still go on small walks, but to go on bigger walks, I have to really push myself and have to rest for days after it. I also really enjoy playing soccer, and I can play a small bit, but I'm not able to play for a team. That was only a few examples, but long COVID has impacted my life in so many different ways. I'm very grateful for everyone around me, especially my mom, who's been very understanding and supportive.
Hi, my name is Julie. I'm Charlie's mom. When Charlie first came down with long COVID, it was really confusing as a parent. They had a fairly mild case of COVID initially and seemed to get better. And then about a month later, basically collapsed. They spent the next year or so mostly in bed, lying down, and even coming to the table for a meal was too much. Over time, sometimes they would seem to get better for a little while, and then any virus that came along, any little cold that the rest of us would get, could set them back for weeks or even months. So one of the biggest challenges as a parent is that you really have to become your child's advocate with healthcare providers, with educators, and even with family and friends. There's a lot of misunderstandings about long COVID. And so as a parent, you become your child's voice, because one of the hardest things for people with long COVID is that on top of being sick is not being believed. So in terms of healthcare, it's been really challenging. There seem to be no treatments for pediatric patients. Charlie hasn't had any treatments whatsoever, and it's been really frustrating to try to find something that can help them. In terms of education, the school really tries to be supportive, but isn't set up to help kids with long COVID. So for example, our doctor had recommended that they do some of their high school courses online, and we were turned down for that. And so Charlie has mostly had to be homeschooled over the past 3.5 years, which hasn't been ideal for them in terms of social connections. So my advice as a parent of a child with long COVID, if you have a child who has long COVID, is listen to your child, believe them, advocate for them, and know that resting is hard work, and it's actually the most important work that they can do.
Wow, so that's a very powerful video for sure, and but very well spoken for both of them in terms of describing what people are going through with long COVID and children going through with long COVID. Now, I have the privilege of introducing our second keynote speaker, Dr. Jonker, whose presentation is entitled Long COVID in Children, Clinical Clues, Immune Insights, and Therapeutic Horizons. Dr. Jonker is presently the Director of Mass General Cystic Fibrosis Center, Pulmonary Division, Department of Pediatrics, and Associate Professor at Harvard Medical School. Since the onset of the COVID pandemic, she has led pediatric COVID research and has helped shape our understanding of how COVID affects newborns, infants, children, and young adults, both in acute infection and post-infectious illness. Dr. Jonker is currently investigating mechanisms driving long COVID in children and leads a clinical trial assessing the impact of larazotide azulin antagonists in long COVID in children and adults. Now, as of November of this year, Dr. Jonker will be transitioning, become the newly appointed chief of the Division of Pulmonary and Sleep Medicine at the University of Texas Southwestern Medical Center, where she will continue her beautiful, interesting, thorough clinical and research efforts. So I'll now open the podium to Dr. Jonker. Thank you.
All right.
You might move these over
Okay.
here. These are for you.
All right.
Okay.
Yep. Thank you.
Thank you.
Thanks for the invitation. I'm really honored to be here. I've had a really wonderful conference so far, so thank you so much for including me and for inviting me to speak. So what I want to talk about today during this session is, three main topics. First, how common is long COVID in children? How do we identify it? I want to talk about what the hypotheses are that are causing these post-acute sequelae of COVID. And then the third section is, what can we do for children or for people with long COVID sort of more generally, but I just want to make sure that we include children in those considerations. So actually, I think we can learn a lot from children. Children don't get the attention that they need in the long COVID space, but actually we've learned a lot from them because they were the first ones to present with post-acute sequelae of COVID. And that was multi-system inflammatory syndrome in children, or MIS-C. So in 2020, we had the acute COVID outbreak, but shortly thereafter, about a month later, kids started presenting to the emergency room, some of whom would go on and have severe cardiac failure, multi-system injury, lots of GI symptoms, rashes, sort of this multi-system, checking all the similar boxes that we're seeing in long COVID, but in a very hyper-inflammatory acute presentation. And now, as time has gone on, thankfully, we're seeing less MIS-C, but we are seeing more long COVID, and there seems to be what we've understood now is more of a spectrum of disease. And so this just highlights the cases of MIS-C. You can see after the Omicron surge, which is that big surge of COVID cases there in orange, the MIS-C essentially went away, which was wonderful, except it's not gone. Just the other day, I was paged by one of my cardiology colleagues saying that a child was hospitalized, and I do think that there changes in the variants of concern probably had some impact on MIS-C, but there's also vaccination, which played a huge role also in reducing the incidence. And so I just I'm putting this as a quick plug that I think vaccination is still important, especially for newborn infants who haven't yet had exposure. So but also there are challenges along with MIS-C that we're also seeing in long COVID. There's no diagnostic test. The clinical criteria is highly variable. There's lots of other things that can cause similar presentations. And so it's essentially a diagnosis of exclusion. So there are a bunch of challenges in this post-COVID syndromes. But sort of switching gears a little about long COVID. So MIS-C's gone away, long COVID is here and continues to be. This is an older survey that just shows that, older numbers that basically anywhere in the US, sorry, I only have US data here, but in the US, anywhere from, it says 17 to 41% of people were experiencing symptoms lasting 3 months or longer following COVID. So that's a lot of people who are having symptoms. When you ask how many people are experiencing long COVID, which is a different question, the numbers are much smaller, so about 4 to 8%. And what's interesting and important, I think, is that difference. So who's considering a diagnosis of long COVID, who's considering persistent symptoms. And I think that there's a spectrum of impact of long COVID, but the fact that so many people are having symptoms goes to show us that's probably on the spectrum, more mild disease, but it's disease nonetheless. And so what causes long COVID? What is the definition of long COVID in children? And WHO came out with a definition a couple of years ago, and it's not that different than the adult definitions. Probable or confirmed SARS-CoV-2, one or more new or persistent symptoms, occurs within 3 months of infection, can fluctuate and relapse, impairs daily function. Symptoms last the year, they have greater than 2 months. The symptoms are not that different, but what I really love about this statement is it acknowledges pediatrics in the name. And I think that's really important. And I don't think that pediatric acute COVID was very different presentation in most children as compared to most adults, older adults. But that's not the case for long COVID. What I mean to say is it's not such a difference. There are different nuances in symptoms for sure, but the concept is still the same. And I like the pediatric guidelines because it just emphasizes that children are impacted. And so looking at how many children are impacted, studies range. Again, I think depends on what question you're asking, but anywhere from 1 to 25% of children report persistent symptoms after having been infected with SARS-CoV-2. And so that in the US is a lot of people. So it's, 700,000 to 16 million children in the US alone. If I do the numbers and sort of extrapolate to Canada, that's 80,000 to 1.6 million children in Canada have persistent symptoms after SARS-CoV-2. How many are diagnosed with long COVID? Much less than that. But again, I think that's more of a diagnostic labeling problem rather than a symptom report problem. So long COVID is hard to diagnose, and we all know this, but we wanted to actually put this on paper as data. So we surveyed a bunch of people across the US, some Canadian colleagues, some European colleagues, and we just asked, we just tried to ask they weren't open-ended, but questions in an unbiased way. So like, what makes you think about COVID? What are the symptoms when somebody presents to your clinic makes you think about COVID? And then what exam findings make long COVID? What exam findings make you think about long COVID as well? And as you can see, there's no one symptom. The highest symptom is still less than 40%, which is brain fog or intolerance of usual activities. But those are very, it's not uniform, which I guess speaks to long COVID, maybe an open-mindedness, but it's very, very vague. Same with exam findings. If there's orthostatic tachycardia, maybe that's what people would think about, but there are other things, and it's nebulous is the bottom line. So what do people do if they're thinking about long COVID? Again, a lot of tests. Not a consistent plan, and maybe that speaks to the lack of guidelines for how to evaluate children in a systematic way. So there's definitely a need there. Blood tests, various subspecialty referrals, but again, not a really solid path to identifying or to ruling out other causes. So we asked, are there any sort of clinical considerations, demographic considerations? And I found this sort of interesting because much more likely to consider long COVID in older children, less likely to consider it in younger children. And I guess that is, that there's some good data. I'll show you that younger kids can have persistent symptoms too, but these younger families probably have even a harder time getting sort of the recognition. Some slight other demographic information that shifts people's thinking one way or another that I think, we just need to be mindful of. And then vaccine status, so that this is probably a little bit older and maybe less relevant now. Other clinical considerations: if a child's school is disrupted, they're more likely to consider it. If they develop a new secondary, like an autoimmune diagnosis or something, more likely to consider. But yeah, there's lots of, if a family member has long COVID. My favorite part of this slide is what makes somebody more likely to consider long COVID is if a family member asks about long COVID. So if you bring it up, the clinician's more likely to talk about it with you. So I tell people if they're thinking about it, bring it up. But there are challenges in diagnosing long COVID. So we sort of talked about the barriers from the clinician side, but there's also, just more general challenges with acknowledging that a child has long COVID. So first of all, there's social stigma. And I think we saw that in the video. I think that was really well articulated. People don't believe that long COVID is a disease, especially in children. Can be seen as a sign of weakness. They have physical limitations. And kids don't want to feel that way. So, so I think that there's lots of complexity there, but I think that being open-minded and supportive of the family rather than jumping to judgment is really important. But long COVID, as with adults, can overlap with other etiologies. We want to make sure we don't miss those other etiologies. But then ultimately, at the end of the day, what's the benefit of diagnosis with long COVID? I actually think that there is a lot of benefit, because we can't make progress without recognizing and calling something what it is, to be able to, connect with others, work together, participate in research, all of those sort of options. So there was this really great study, the Recover study that you may have, read about, where a group had this huge, survey that was sent to over 5,000 children right around the Omicron surge. So it was a little bit later in the COVID pandemic. But what they did was they asked people if they'd been infected with SARS-CoV-2 or not. And there were still a fair amount of people who had not, because of the schooling situation, hybrid home schooling options. And then they confirmed that with a blood test, which is really important. And they asked symptoms sort of after they'd had COVID multiple times. And the bottom line is that 1 in 5 children experience symptoms of long COVID. And what's really great about this survey is, again, they were comparing to everybody in the same sort of time frame, whether or not they were, impacted by school changes and social disruptions. So that sort of, mitigated some of those potential social confounders. It's a little bit blurry, but I want to highlight some of the symptoms that are reported in children. So there's actually a couple different slides here, but this one is in children ages 6 to 11. And there's a list of symptoms, which I know you can't see clearly here. I'll walk through. But what I want to show you also is those arrows on the right. So the line down the middle is, is comparing symptoms of those who were never infected. So people who were never infected, confirmed with blood tests, what were their symptoms report? That's the sort of baseline. And then the symptoms, the dots and the lines are symptoms reported by people who had prior SARS-CoV-2 infection. And what you can see is the kids ages 6 to 11 who had prior SARS-CoV-2 infection had just more fatigue, difficulty sleeping. They were tired after walking, so post-exertional malaise. They had more likely to have palpitations during exercise or feeling lightheaded or dizzy, much more stomach pain, nausea and vomiting. They had much more joint pain and body pain, headaches, brain fog, and they had more anxiety, more fear about things, more fear about crowds, more school refusal. And so this is, these symptoms are similar to what we see in adults. Might not be something that you can see by looking at a patient, but but they're reporting these increased symptoms, and this is significantly impacting function. Similarly, in adolescents, 12 to 17, they looked at these symptoms, and again, the sort of graph to the right, the central line is if you never had COVID, and then the dots and the lines compare what the responses are for those who had SARS-CoV-2. Again, similarly, fatigue, post-exertional malaise, more likely to have persistent changes in smell or taste, feeling lightheaded, GI symptoms, pain, headache, brain fog. And so, then a study just came out over this last spring, looking at long COVID in infants and toddlers. And this, I really love this study too. This was a smaller cohort, about just shy of 500 infants and toddlers. They did not have blood test confirmation because drawing blood in young children is never easy. But they compared based on parent report of whether or not somebody was suspected to have COVID or was exposed to COVID. They grouped them into never having COVID versus those who did. And they again compared symptoms. And what's interesting is even in this younger age group, children who had COVID were twice as likely to experience prolonged symptoms. This group's a little interesting because it's slightly different. The questions are different, right? They're not going to tell you if they feel dizzy or lightheaded. They're not going to tell you if their stomach hurts or if they're feeling nauseous, but you make observations. And so the things that they, let me see if I highlighted it. I did not. The things that were, most prominent in these groups were poor appetite. So probably some GI symptoms, trouble sleeping. Interestingly, they had a persistent, more likely to have a wet cough or dry cough and stuffy nose. And then similarly in the slightly older preschool age children, they had more fatigue or lower energy and a persistent cough. So this is a really nice overview of the symptoms that I think we should be asking our pediatric patients about and considering long COVID. So this is, take a picture of this. This is a good one. JAMA pediatrics patient page if you wanted to look it up. But yeah, I love this. It breaks down the sort of the questions to ask, and it highlights that long COVID is a diagnosis that children can experience. And I think that's really important for us to keep an open mind. And so what are the signs and the symptoms too? So we talk about symptoms, but what are the sort of more clinical signs? And in children and same as in adults, cardiovascular symptoms are quite common. POTS, and just persistent tachycardia is very common. This is an older study. This is an adult showing that POTS is quite common. This one's more specific. This slide is more specific pediatric data, but in children, 71% of children with long COVID have orthostatic intolerance of some sort. There's also, based on EKG assessments, have been findings, differences in autonomic cardiac function, and some, functional impact too, some abnormalities in cardiopulmonary testing. So there's not only these symptoms that people are reporting, but there's true objective signs as well. There's also, that's sort of focusing on the cardiac side. There's also persistent neurologic and psychologic sequelae after COVID too. This is actually looking at multisystem inflammatory syndrome in children, or MIS-C. And this is looking at, persistent impact on memory, executive functioning, and various psychologic outcomes. And what they found was kids with MIS-C, so again, after COVID, had persistently, this was a 6-month follow-up, persistently lower memory, executive functioning, higher scores for depression, higher somatization, and lower quality of life. That was 6 months later. And then they did a study 2 years later, looking at the same outcomes. And I was texting on the app earlier about this sort of concept that the title was "Most Children Improve with MIS-C at 2-year follow-up." But then if you look at the data, 60% of those children who had symptoms improved. So that's great, but there's still 40% who still have persistent symptoms 2 years after they'd had MIS-C. And that tended to be those who had more severe acute illness. But that's just to say that I think we have to be careful with our optimism towards kids. And again, keep an open mind. We want kids to get better, but we can't wish it upon them. We have to think about all of those kids, some who respond and some who don't. Okay, so to switch gears a little bit, I want to start talking about some hypotheses that we're sort of studying about what causes long COVID in kids and also adults. But what I like about kids is they don't have all of those age-related comorbidities that we all accumulate over time that can, make the picture a little bit more murky. They're healthy. Their bodies are healthy until they have this one illness. So as we know, after you've had acute COVID, you do generally clear the virus from your airway within 10 days. There's lots of data. This is just to show that there's lots of data, not to show any specific study, but lots of data to show, and this is a little bit, a year old, that there's reservoirs of virus and lots of reservoirs in the gut that have been proven by biopsy or various testing, but other places too. And so, but regardless, there seems to be SARS-CoV-2 that's persistent in the body. And that's not unique to SARS-CoV-2. Lots of viruses will persist in the body, but it's important as far as what that means for long COVID. Because having these persistent viral reservoirs increase gut permeability, they disrupt the gut-brain barrier, they cause microclots, they cause shifts in the immune system, reactivation of other viruses, it impacts metabolism. And so there's lots of consequences that many researchers have shown. And so we need to better understand what we can do. So, again, I think we can learn from Miss C. And so we showed sort of early in the pandemic, this was published in 2021, what seems to be a leading, again, hypothesis, but what it seems to be driving Miss C. And it starts with persistent SARS-CoV-2 in the GI tract. So this is sort of the first recognition, or one of the early recognitions, that you can have these persistent reservoirs. So we detected it. We had found RNA in the stool. And then we looked at markers of gut, breakdown of gut barrier dysbiosis, which is zonulin. And zonulin was increased, which means the tight junctions in the gut were loosening. And then we also found spike in the blood. So pieces of the virus, the spike protein, was leaking into the blood. And that was correlating with this hyperinflammatory response that characterized Miss C. And lots of people defined that immunoprofiled that hyperinflammatory response. And so what we've been seeing over time is there's this spectrum where Miss C being the most acute presentation, but then long COVID follows the same pathology. And I've already showed you multiple studies that suggest that there's SARS-CoV-2 in the gut. Others have shown that there's zonulin that's increased in long COVID. And then lots of other people have also recognized that there's spike proteins in the blood of long COVID patients. And again, there's lots of data out there to show hyperinflammation. And I'm not going to, just to touch on this, there's lots of immune activation, especially neutrophil activation. I'll show some data too. Microclots, there's elevated anti-SARS-CoV-2 antibodies, there's abnormalities in T cells and B cells, and then autoantibodies. And so I'm going to show you a little bit of unpublished data. Hopefully, we're submitting this soon, but we've done some profiling in long COVID. But what's really important is that this is in children with long COVID. We have some, I like to call them young adults up to age 50. And so, but we're skewed towards pediatric. So the average age in our population is, I believe it's 14. And so most of the patients here are younger. We have healthy pediatric controls as well. And we also included Miss C again to try to see what the spectrum of neutrophil activation is, knowing that Miss C is very hyperinflammatory, and try to see where long COVID comes in. And so the really most prominent finding that we found was that neutrophils are just undergoing this neutrophil extracellular trap formation. And so that's when basically a neutrophil explodes and releases its contents. And in its contents, that's good if there's a bacteria or a virus nearby, because it ensnares that virus and kills it with its proteases, elastases. DNA is very sticky to help sort of create this web. But if that's just happening in your bloodstream or by your vessels, elastase, things like this, or wherever around some sort of tissue, that can actually be harmful. And so, what we're seeing is that let's see if I can do this. And we know that we've already published that there's a lot of neutrophil activation in Miss C. And in some of these patients with long COVID, it's actually about the same, statistically not different. than those we're seeing in MIS-C. And especially those where spike is detected in the blood. And those where we're not detecting spike, it's still elevated compared to healthy controls. And we did this with a couple different ways. We first of all, and I'm going to show you a video, hopefully, where we put the neutrophils on a dish and we just watched what happened to them. But we also looked for indirect markers of extracellular DNA, cell-free DNA, and that was, again, increased, sort of validating our functional microscopic findings. And here is what I'm going to show you videos of. So this is our little device for looking at these neutrophils. We put neutrophils in a dish. We isolated them, put them in a dish, stained them with just DNA stain. And then we had this other green stain that looks for DNA once the membrane is broken down. And so once you see this turn green, so once these tight little neutrophils loosen up, they turn into little blue balls as the DNA is loosening. And then when the membrane breaks down, they become green, little tennis balls here. And so again, healthy neutrophil, this is a neutrophil that's netosed or undergone a neutrophil extracellular trap. So let's see. Okay, so here we have on the left healthy neutrophils, again, placed in a dish and just observed. And here we have neutrophils from long COVID. Let's see what happens. So here are the healthy neutrophils. You can see them, they stay tight. You can see this really nice membrane. It's really intact and they're just sort of hanging out. And then over here on the other side, these are just the blood, the neutrophils we put in a dish. You can see, you know, they're starting to slow down. They're a little stickier. And then all of a sudden they're just sort of all exploding. So they're just not as stable as happy. They're more likely to undergo these neutrophil trap formations. So then we wanted to understand, you know, what's causing this neutrophil, this neutrophil extracellular trap formation. And so our hypothesis, based on what we saw in MIS-C, is that the spike and the immune complexes are actually triggering these neutrophil extracellular traps. And so we took antibodies and we mixed them. We sort of created these immune complexes. We took antibodies from vaccinated patients. We took spike that we bought and we put them together to generate these immune complexes. And then we added those immune complexes to healthy neutrophils and watched them under a dish. We did some other assays, but I'm not going to talk about those today. And in this, we saw that if you generated these immune complexes with antibodies and spike, there was a dose response. So the more antibody and spike combinations that you had, the stronger the net profile. We saw a lot. And so what that made me, you know, sort of think about is maybe there's, you know, maybe there's some fluctuations in the leakiness of the gut, if that's where the spike is coming from. And the more spike that's leaking into the blood, the more of an inflammatory response. And, you know, maybe that has to do with symptom fluctuation. I'm not sure, but it seems as though these immune complexes and spike leaking into the blood is definitely activating the neutrophils. And so, you know, what is it doesn't sound like that's a good thing to have these neutrophils releasing these extracellular traps throughout the blood, but we wanted to understand, you know, a little bit more. Does this impact any of the endothelial symptoms that people are experiencing? And so, again, this is unpublished, but we're submitting it hopefully this week. But this is, you know, we have our symptoms reported from our patients. Again, a pediatric skewed cohort. So these are, again, important to include pediatric patients as we're advancing science. So they're not, you know, again, I think the benefit is it excludes all those inflammatory comorbidities, but it also validates objectively that what we're seeing is they're having differences from healthy controls. So here are all the symptoms that we can see, typical symptoms that people report. Dizzy on standing, shortness of breath climbing stairs, palpitations, feeling faint, chest tightness, long-lasting hands, cold in the hands or feet, chest pain, and then swelling in the hands or feet. That's less common, but still reported in about 25% of people. And we looked in the blood and we saw, you know, we had a really great talk by Dr. Rio yesterday about fibrin clots. Here we were looking at microclots in kids, and we did see increased microclots in children with long COVID. So you can see the number, the microclot burden is higher. The total number of microclots was higher. The size of these microclots are higher. And, you know, and here's just a few examples of the things that we would see. Some would be little clusters, some would be sort of rounder, sort of almost cuboidal little objects. And then some seemed as though they would almost follow a shape of a little capillary or something. So we were definitely identifying these, and we developed a screening, sort of an objective screening strategy. So we were able to not just identify them, but really quantify them in an objective way. And what we found was components of microclots, which are amyloid and fibrin, correlated pretty strongly, pretty significantly with cell-free DNA, which is a marker of these neutrophil activations. So we wanted to look into that a little bit more. So we had we created a in vitro co-culture model, which is it's a little blurry here, I apologize. But what we did was we treated endothelial cells in a culture dish, and we treated them with either spike or immune complexes, or we treated them with these neutrophils that were stimulated with the spike immune complexes. So they were releasing nets, and we added them, and we wanted to see what sort of markers of injury we found. And as an example, we looked at LDH, which is a marker of cell death. And so if you have these neutrophil extracellular traps occurring near endothelial cells, that does injure the endothelial cells, and they release a lot of LDH. So the endothelial cells are not happy in the presence of these neutrophil extracellular traps. And that's what we were sort of expecting, but it was nice to see this data validated. And so to sort of step back and pull it together, I think this is the hypothesis that we're working with. So there's viral reservoirs in the gut that causes dysbiosis, which causes zonulin release. Zonulin leads to a leaky gut, and spike can then traffic into the blood. When the spike is in the blood, it's bound by circulating antibodies. Those immune complexes activate neutrophils, releasing neutrophil extracellular traps, which injure the endothelium and correlate with microclot formation. And so if we're thinking about how to treat this, and there's definitely things we can clear the microclots, we can suppress the neutrophil response, just hypothetically speaking. We can clear the spike, or we can mitigate that leak from the gut, or we can treat the viral reservoirs. And I actually think it's probably ultimately going to be a combination of strategies that's going to be needed. But right now, where does treatment stand? In treatment, there's two sort of strategies. There's treatment of symptoms, which is where we stand now, and then targeted specific treatments, which is what I was sort of just talking about, but that's really where we need to get. Right now, the strategy that I use, I've learned a lot from my ME/CFS colleagues about how to support and treat and rule out other causes of the fatigue, post-exertional malaise, and POTS symptoms, dysautonomic symptoms. And so I as a pediatric provider, this is what I lean on a lot to try to support the kids that I've encountered. I don't want to go too much into the workup, but I do like to include the orthostatics. There was some great poster yesterday talking about how that can be persistent differences. I do lab work to rule out other causes. And then treatment with, we had a nice clinical talk yesterday talking about hydration, salt, electrolytes, compressions, and then medications. And again, all of these can be done in children. And the top three are not hard to do. And the medications, there's not an extensive list, so it's sort of gaining familiarity. And I do think that this can be done in the primary care office and close to home. And, one solution is you have to work like many diseases that don't have really perfect targeted treatments. You have to figure out what's best, and that's really best to do with somebody close to home. So But ultimately, where do we need to go? We need to find specific tailored treatment strategies. And so I talked about the mechanism. Here is just a graphical overview of how I think about it. So we have, targeting viral reservoirs with antivirals. That would be great, but we're not there yet. Targeting antigen leak, that's something that I'm working on and I'm going to show you a little about. And then targeted inflammation or microclot formation or fibrin are really great strategies too. I think that advocacy is so important for children. Children are excluded from most research and they shouldn't be. You try to protect children, and that's why there's lots of sort of steps to getting towards including children in research, but that doesn't always have to be the case if you're testing something that's already clinically improved and used in children, for example, like IVIG. So I think that there's lots of considerations for accelerating inclusion of children in research, and we all need to consider that as we're doing our own research. I want to just touch base. I'm getting towards the end of time, but I want to tell you a little bit about something that we're doing, which is the treatment of lorazepatide for post-acute sequelae of COVID. And we did a study in MIS-C, and now we've moved on to long COVID. So I'll show you the data in MIS-C. Basically, lorazepatide is a zonulin inhibitor. So I mentioned SARS-CoV-2 reservoirs trigger zonulin release. When zonulin binds to its receptor, it breaks down the tight junctions, and then small particles like the spike protein can leak into the blood, and that causes an inflammatory response. Zonulin acts by binding to the zonulin receptor competitively so that the tight junctions remain intact. And what we've seen as a result is there's less spike in the blood, and the inflammatory response reduces as well. And we did this open label first, and we saw some, it was a small group. We treated 4 children with lorazepatide in the setting of MIS-C, and we did see an improvement in GI symptoms, an improvement in spike clearance. So then we did, I'm sorry, this one's blurry too, a double-blind placebo-controlled study of MIS-C, and this was published earlier this year. But what we saw was, again, in this double-blind placebo-controlled manner, there was faster improvement of symptoms. So by 7 days, the group on lorazepatide were more likely to have resolved their symptoms, and we were really focusing on GI symptoms at that time, but they were feeling better. And then we also saw, even by day 7, they were more likely to have cleared spike from their blood. And this persisted over time. And even at the end of the treatment at 21 days, there was still one of the children who was treated with placebo who still had spike detected in his blood. And so there seemed to be good evidence that it was helping mechanistically clear spike. And this, they were able to, kids who were treated with lorazepatide and had spike cleared from their blood were more likely to return to usual health and usual activities. So there was an impact on quality of life too. And I don't think I show this here, but this seemed to last actually, because we followed these kids for 6 months. Now we're enrolling in a long COVID study of lorazepatide, and it's the same concept. We are enrolling 150 patients. We've extended the ages, so it's not just children, but it's children up to age 50. And we're doing a 2-to-1 randomization. So 2 people get lorazepatide versus 1 gets placebo. And it's a 21-day treatment and then a shorter follow-up, a 28-day follow-up. We started this after the MIS-C study. And so we got feedback from our MIS-C patients. I think there would be things that I would change at the next phase, but right now we're running through the study, and our goal is to really wrap up enrollment by the summer so we can get some data. We're working very hard. And hopefully I'll be able to share that at some point. But if you're interested, or, in sharing with, if you're personally interested or want to share this with colleagues or patients, or there's the QR code, and I think I have it again at the end. And we're also using the samples that we collect for understanding the pathomechanism driving disease. So no matter what, we're learning a lot. So in summary, post-COVID symptoms are common in children as well, and long COVID is undeniably underdiagnosed. Pathology is likely related to persistent viral reservoirs and the resulting inflammation. And treatments currently target symptoms, but what we ultimately need is really more specific therapies. And those, I think there are some promising things in development. And so anyways, just want to say thank you. My contact information is there. Feel free to reach out. And there's the QR code if interested in the study. Thank you. Any questions?
Hello.
Thank you,
Yep.
Dr. Yonker. That was a very beautiful, clear, methodical approach to pediatric long COVID and state-of-the-art research that you're giving us unpublished research that's ongoing now. So it's very impressive. So we open the floor for questions. We'll take questions here, and we have some online questions as well. So you're the first person for a question. Thank you.
Hello, great talk. So I was having a conversation today with one of the PIs, and they had a bit of skepticism regarding ongoing viral reservoir. So there's an interesting question. How do we know the reservoir isn't due to subsequent asymptomatic infections? How can we be sure?
Yeah, no, it's a good, it's a good question. So I guess even with asymptomatic infections, we shouldn't see, and we've looked actually at mild COVID. You shouldn't see spike in the blood, mild infections. With severe infections, you can, but you usually don't see spike in the blood with acute COVID. So we're seeing spike that's in the blood in patients with long COVID, which ongoing, too, many years out. Could they have just had a recent, it seems like the numbers seem, like that seems like a lot of like rolling the dice a lot of times and getting a lot of people who just had a recent infection, but they still shouldn't have spike in the blood. So I think that, I do think that there are reservoirs. I think the gut is one of them. There are probably other sources. And, but I think that the science seems to really suggest that there's underlying reservoirs. And again, that's not something that is implausible. It happens a lot with other viruses. But the spike and components of the virus are immune activating. So I think that it's hard to argue that there would have been a recent, a recent exposure, and then we just happen to be sampling all of these patients at the exact right time. I think there's a couple things. So I do think that it's a challenging, there are people who are still needing to be convinced about that, but I think that the data is really there.
Okay, because there are some people who get long COVID even after asymptomatic infections, for instance.
Yeah.
So like, would you say there's a reservoir just not as noticeable? So they don't have the spike protein in the blood, but maybe it's more hidden in certain tissues, or?
Yeah, exactly. So I think it doesn't, I don't think it correlates with the severity of the acute COVID. Often it's a more mild response, but it's just, and I haven't, looked at comparing the quantities of virus that have been seen in the gut, for example, but yeah, it's a good point. It doesn't have to correlate with severity.
Thank
Yeah,
you.
thank you.
Good. Thank you. Susan, do you have a virtual question?
Good morning. I do. There are several very good questions. I would encourage our speakers, if they have time, to sneak into the HOVA app and see if you could answer some of the questions, because I'm not going to be able to represent them all. But there are a couple of questions about the longer term consequences for toddlers and infants who contract COVID or long COVID, in terms of what are the longer term effects, neurodevelopmental issues, motor cognitive language issues. Are these deficits corrected over time, and when? And are they permanent or temporary?
Right. No, that's a great question. And I have to say that this acknowledgement, this Recover study that just came out last spring, recognizing that these symptoms are present. I don't know of the follow-up studies beyond then, but those are very important questions that we have to be watching carefully for, because we need to make sure that we address those challenges to get kids on track.
Okay.
Hello, Dr. Yonker. Thank you very much for an excellent presentation. I'm Dr. Fumio Kanola, a practicing family physician in BC, and with long COVID, the answers. I think your presentation today has highlighted our need to protect our children in our schools is urgent. SARS-CoV-2 is a grade 3 biohazard, and we are freely exposing our children to it. And you've clearly documented here, the acute and long-term effects of this exposure. How can we kind of join this information up? We have campaigns going on for air filtration and ventilation in schools that are being ignored by authorities. We have a disease that's looking like it's going to be or is more prevalent than asthma in children. If we're looking at 1 in 5 children, we're talking millions and millions, which is really scary. How do you think we can kind of inform the public of this and get some protections for our children in schools in view of the evidence that you've displayed today?
It's a great question. I think clean air quality is something that is very doable and should be prioritized. It's not just going to improve, or reduce the likelihood of transmitting viruses, but lots of other allergens and things like that can impact a child's lung. Can be addressed with clean air in schools. So I think that's an important priority. Vaccination protection, I believe is also really important to protect against getting illness. And vaccination does protect against long COVID, reduces the risk of long COVID too. So I think that those are important strategies. But yeah, I think that there's certainly more work to be done.
Yeah, I mean, I'm not laying all of that onus on you. You're the scientist that's producing this amazing information, but I think we somehow need to get together and get some form of joined up communication into social media so that people are aware of what their kids are being exposed to and demand change, which really would be very cheap to implement. Thank you so much for everything you do.
Thank you. Susan, do you have another virtual question?
I do, thank you. From one of our virtual participants, given the complexity of pediatric long COVID across the world, what are the key steps to forming an international interdisciplinary team or group to develop standardized guidelines for clinical diagnosis and safe care, regardless of the different countries' healthcare landscapes?
Oh, fantastic question. I think that honestly, talking with Rebecca, the patient advocate here today, as we hiked Signet Hill this morning, by the way.
Oh, did you?
We did. It was beautiful. Highly recommend it. But I would say, honestly, patient advocacy, it's challenging, and we all have, the long COVID complicates our lives, and it's hard to do. But I think organizing advocacy at the government level, at the getting honestly funding to be able to support getting people involved in guidelines, getting research going, getting, clinical initiatives to be able to support things and prioritize long COVID it's just essential. I've sort of realized that over time. And so, as a patient, joining efforts to advocate together, not just internationally, really would be so important. Learn from one another, trying to raise this as a priority across different governments is just, I think that's really important, and that's going to probably have the biggest impact.
Next question, Erin.
Sure. First of all, thank you, Dr. Yonker, for a phenomenal work that you're doing that our children need in this area. So I just had a quick comment and a question. The comment, I think it's really fascinating for me to see that you guys are using Larazotide, and the fact that you just mentioned about funding. It was very heartbreaking to see that Larazotide, the phase 3 trial, with no safety or other implications, going very well, was just pulled off because of funding and the trial design issues for celiac patients. So it's very important to use these drugs and repurpose them and continue our research, for our patients, for our children. So that was the comment. The question, I just had a quick question. What kind of assays were you using to assess the microclot burden? Because I know traditionally people are using the quantitative assays. And I saw that a group from Mass General actually is using the microfluidic assay, which is the quantitative assay and has a, like 94% sensitivity as opposed to the qualitative around 66%. I was just curious about that. And thank you very much for being here.
Thank you so much. Yeah, no, I do think, again, going back to that advocacy component is, you know, running clinical trials, you have to pay a lot of people to be able to do those, and you just need to, you know, there's a funding pipeline, I think, that needs to be supported long term. So thank you for that comment. As far as the microclot, so I was part of that group, a good collaborator of mine. We worked together on that. But what we've done for this is we've tried to make it as objective as possible. We don't want to just look around and be like, there's a microclot, and cherry pick. We wanted to have a standardized. So we have a grid that we've created, and we fill it with a standard amount, and we run the grid, and then we, you know, so we are scanning a large area so that we are able to represent in a non-biased way, and then we analyze. So that's how we overcame that.
Thank you. Susan, do you have other online questions?
Computer's just refreshing here. I think I'll ask this one actually about universal and free vaccination access. Again, it goes back to the advocacy, but what can patients do to overcome some of these barriers, particularly, for instance, in Alberta, where they now charge $100 for COVID vaccine unless there's some particular chronic illness? Thank you.
Yep, great questions. No, the vaccine landscape is challenged these days in the US as well. And so yeah, I don't know that I have a great answer for that. You know, I encourage people to get the vaccine to work with but it's challenging as well in the US. And so again, voices with scientific background are really important. Having patient advocates join those, working together. So for example, the American Academy of Pediatrics has decided that, you know, they're going to split from what the CDC recommendations are because they disagree at this point, and follow what their evidence-based opinions are. And so there's disconnect these days. And so I think just trying to support and raise, you know, and raise awareness about the importance of vaccinations, I think is just, you know, the advocacy component, again, is the best recommendation. And I'm sorry that people are experiencing those challenges.
Yes, thank you. And last question for Stacey.
Thank you. First of all, thank you very much for this presentation. It was super easy to follow, well explained. And thank you for shining light on children who don't have a voice, right? This is clearly a problem, a widespread problem. And I feel really strongly about it. In terms of advocacy, as you said, one thing that I've been struggling with, even in Newfoundland and Labrador, is trying to get people who are actually in charge of the decisions to sit down even and talk about it. But maybe reaching out to some of the, like, if you're looking at like the Department of Education and Student Services and things like that, and speaking to those individuals. But one thing that I noticed that I tried to tie in to the student services manager when I was having my meeting was, I said, you know, it seems like we're seeing an increase in behaviors, right? And everybody sees an increase in behaviors because, you know, it's tangible, you see it, they record it in schools and things like that. But when children are not able to communicate how they're feeling, they may feel off and not really understand it. They may just be irritated, sensory overload, as many of us with long COVID have, but they're not able to communicate that clearly, so it often comes out in behaviors. So the minute I said that to her, she was like, okay. And then I started explaining post-exertional malaise and how some of like your overachievers in the school who are, you know, in all the sports, doing all the things, getting, you know, top marks and everything they're doing, they're going to keep on trying because that's their nature. And unfortunately, because we don't understand post-exertional malaise and schools do not understand post-exertional malaise, we don't have those individuals to try and help children pace themselves. So when I started explaining some of that terminology to her, I could see her taking notes. She asked for information. And I think that that's something that maybe like from the advocacy perspective, we need to consider is maybe working a little bit from the top down and trying to see to get the talk going within our school systems for children. And then maybe if we're hearing it from the school systems, then maybe we might get some more help in healthcare, right?
I agree.
So-
Thank you for your awareness and your, communication with the schools. It is really important.
Anyways, it's really important work you're doing, and I wanted to say thank you.
Thank you.
I think we have one more question and then we're going to take a break. Go ahead. Thank you.
Thank you so much. Thank you, Dr. Yonkers, for your presentation. Just to follow up on what the last commenter said, I've been seeing a lot in media, especially in American media, that the reason why we're seeing these symptoms in kids is because they're pandemic kids, that they were stuck at home for 2 years, and that's why they're having these symptoms in schools. And I'm curious what you think we can do from a medical and advocacy standpoint to kind of push up against that narrative.
Oh, I think the recovery data that I showed perfectly argues against that, because that takes kids in the same time. Everybody lived through the pandemic. Everybody was sent home from school, and schools were closed down. They all experienced that. So that's at the level playing field. And then it looked at specific symptoms with or without SARS-CoV-2 infection. So I would, use that study to say, it's not the pandemic. It's not situational. It's because of infection.
Thank you.
Thank you.
Great. Thank you again for a wonderful presentation. Thank you.